Okay. Thank you very much. I wanted to specifically thank Wendy, Becky, and Bob for inviting me here today. And what I chose to talk about was really some of the updates on encephalitis. I titled the talk, Chasing a Moving Target, because there's really a lot going on. And I thought this group may well already be aware of some of the advances and some of the new findings, but hopefully I'll be able to emphasize one or two new things. My objectives for the talk today are to define what is encephalitis and discuss the scope of encephalitis, then to talk about some of the new findings. We have some new organisms that are emerging as important causes of encephalitis. There's some new drugs I want to discuss. There's a new diagnostic technique that looks very promising. And then we'll end by talking about what are known about knowledge gaps and opportunities. And I don't have any financial disclosures, but I do have some disclosures for you. Oh, went backwards. I'm an ID physician, so what I focus on in my professional life is infections. If this talk was being given by a neurologist, you'd hear a different focus. Much of what has been discussed already this morning is really on the post-acute sequelae of encephalitis. So you're going to hear a little bit of a different focus or aspect of encephalitis. You've already probably figured this out. I tend to talk too fast. So if I do talk faster than is understandable, you guys can just give me the sign and I'll slow down. For 10 years, I ran the Tennessee Unexplained Encephalitis Surveillance Study. This is the counterpart to the California Encephalitis Project. We enrolled 794 patients with encephalitis and did diagnostic testing, looked at epidemiologic links, and did some outcomes work as well. But primarily I'm a clinician, which means I see patients day in and day out. And as a clinician, I have to say that the most challenging patients, the ones that keep me up at night, the ones that I think about, what did I do or what could I have done differently, are those with encephalitis. And I'm not alone in this. If you ask my colleagues, a lot of them would say encephalitis is one of their least favorite diagnoses, not because they don't like you guys, but because it's really, really challenging. Encephalitis is problematic in that it's hard to recognize, and we've heard about that already. There are a large number, there are over 100 different organisms that have been associated with encephalitis. There's also a lot of non-infectious causes of encephalitis, and again, we'll touch on those as well. No. Diagnostic testing can be extremely challenging. This is something our fellows really struggle with. It really depends on what test is done at what time in terms of the yield. Yes?
Your computer is blocking the screen.
That will help me too, because I can't see it very well. Better?
Yeah.
All right. In less than 50% of the cases, we find an organism, again, incredibly frustrating to you guys. It's actually frustrating to us as well. There are not many treatment options outside of antiviral therapies and now steroids. And of course, this is a very, very severe syndrome, and I don't need to convince any of you of that. So what is encephalitis? There's actually a clear-cut definition, which I have listed here. Encephalitis entails neurologic dysfunction with inflammation of the brain parenchyma. So basically, some form of confusion with abnormalities of the brain. This can be infectious, and it can be autoimmune as well. In contrast, encephalopathy is neurologic dysfunction without inflammation. And there's a lot of overlap in these, and so you can see this sort of list of non-infectious etiologies that can cause encephalopathy. Okay.
Could you identify or define what is autoimmune?
That's a great question. So autoimmune is a phenomenon. We're going to delve pretty deeply into this later in the talk, but just to sort of give a preview of coming attractions. Autoimmune is when the body uses the immune system to attack parts of itself, often triggered by something, whether it's an infection or some insult. So autoimmune just means a disordered or dysregulated immune system that, in this case, would attack brain tissue. All right, so while these look like very nice, clear-cut definitions, the problem with them is they're pathologic definitions. And we don't get to sample brain tissue, thankfully, very often anymore. So most clinicians would use the Justice Potter Stewart definition of encephalitis, just like he defined pornography. I can't tell you what it is, but I know it when I see it. So I say that sort of fastly, but it's really a challenge because pathologic definitions, we're not going to get brain tissue. We shouldn't get brain tissue in those cases. And so we have to define some clinical correlates which go along with brain inflammation. And there are a number of these, but not any single one of them is a perfect approximation. And this lack of a case definition is significant because it impedes recognition, so sometimes we don't even know it's encephalitis until somewhat later in the case. It's very hard to compare studies when you use different case definitions for encephalitis. So if one author uses one definition, a second author uses a second one, and their findings are different, it's extremely hard to know what to make of that. And then you can't count something that you can't define. So societal burden is very, very difficult to assess without knowing what we're talking about. So I'm going to do a segue here. You guys, I think, are familiar with the International Encephalitis Consortium. And I'm going to just give some background on it because I'll be referring to it later in the talk, and I know Becky will be as well. This was started in 2010, and I want to give a shout out to one of the previous speakers here, Carol Glazer. Carol really was the founding member of this, and really her enthusiasm and her drive and her passion made this happen. This is an ad hoc group, all of whom had research interest in encephalitis, but it comprised a number of different disciplines, researchers in neurology, infectious diseases, rehab medicine. Some of us were clinicians, some of us were in the lab, and then later on we were lucky and privileged to have survivors join us as well. As the name specifies, it's an international membership. And the first meeting was held in 2012 in Atlanta. And one of the drivers of this meeting was that members of the group recognized that there were some real deficits in encephalitis. Case definition I've already alluded to. Diagnostic algorithms, that means what kind of testing should be done on every patient every time. And so it was felt that these were two areas that this group could impact care on. And I won't go through it, but at this meeting, a proposal was put forward and then published to develop a standardized diagnostic criteria for encephalitis. And so I think that this now has sort of become entrenched and is being more widely used. And again, I won't go through the specifics of it, but it's a standardized way to define what is encephalitis. It requires altered mental status for at least 24 hours and at least 2 of those other variables for possible, and then 3 or more for probable or confirmed. So hopefully having this definition will help improve defining what the burden of encephalitis is going forward. But I wanted to talk about what the burden of encephalitis is, at least in the last decade. This is data by Neil Vora, who's out of the CDC. It was a huge undertaking. He looked at hospital discharge diagnoses nationally. And he and his colleagues identified a total of more than 260,000 cases of encephalitis. So that averages to about 20,000 cases per year. In this cohort, mortality was about 6% and was certainly higher in the immunocompromised population. And the charges were quite significant at $2 billion. And those are just direct hospital charges, so that doesn't take into account post-hospital care, time lost from work, time lost from wages, caregivers lost from work. So there's a lot of indirect costs that weren't captured by this analysis. The other thing that this study showed us is that over this 10, 12-year time period, the rates of encephalitis were relatively stable. And that's shown here by this black line, which is sort of surprising because, as I'll talk about, during that time period, there have been a number of new causes of encephalitis that have been identified. And I would have guessed that that would have driven the numbers up. The other thing that's notable about this slide is that even over this 12-year time period, the proportion of undiagnosed cases did not change significantly. So I think the blue line is cases that had a diagnosis. The green line is undiagnosed cases, and again, those are really interweaved, so about 50% of cases remain undiagnosed. And I think people could say, well, the way the study was done, it's really hard to use these very imprecise ICD-9, now 10 codes to quantify, diagnosis. Sometimes diagnoses are made after hospitalizations. This is probably not the best way to do determination of proportion of diagnosed. Well, this is data from the California Encephalitis Project. And again, many of you are familiar with this. This was a prospective study. There was very advanced testing done. Carol Glazer was the prime author on this one. And she had the resources of the California Health Department, the CDC. She had independent investigators who were doing really novel and innovative things looking for pathogen discovery. And even with all of this resources being devoted towards these patients with encephalitis, in her study, 63% of patients did not have a diagnosis. So it's actually worse than national. There are probably reasons for that. One of the reasons is that patients were often referred into the study only after they tested negative for sort of the core things that we look for, things like herpes. But that being said, that 50% number is probably not an anomaly. So what are we missing? Probably the largest thing that we're missing are common agents that are just not looked for at the right time. And that's a real tragedy. We're also missing cases of rare diseases that are just not thought of or considered in the differential diagnosis. Finally, it's becoming increasingly clear that at least in the past, and probably into the future at least, there are a lot of non-infectious things that look like infections. They present identically to infectious encephalitis, and which weren't considered. And then there's always the possibility that there may be new or unknown organisms that sort of make up at least some component of those 50% unidentified. Yes?
Doctor, could you give us an example of this relatively known common agent?
So I'll be giving some more, but herpes simplex virus 1 would be the most common viral, or the most common infectious cause of encephalitis in the United States. And it is one of the treatable causes, as we'll talk about, and unfortunately it is not always picked up. So that would be a great example. West Nile would be another one. So one of the priorities of the International Encephalitis Consortium was to optimize or define what the standard workup for every patient who presents with encephalitis should be. And I think this is so important. It's not the first group that tried to define it, but I think the schematic sort of gives you an idea. The prior diagnostic strategies were incredibly complicated and incredibly detailed, and I think really tried to highlight identifying those rare causes. I think when we met in Atlanta, we recognized it was really important to recognize the common causes, and then in select circumstances, look for these zebras. So it really was an attempt to simplify this for doctors in the community as well as in tertiary care centers. Okay, with that as background, I'm going to segue and talk about selected causes of encephalitis. Any other questions before I move on?
What is a mimicker?
Something that looks like an infection but is not. And we have a number of folks here with autoimmune diseases. Again, the presentation can be absolutely identical. They're usually seen by infectious disease doctors in the hospital. We run a huge battery of tests on them, but it turns out to be, again, this autoimmune phenomenon where the immune system is attacking brain tissue. So I could give antivirals or antibiotics, and I would not impact this syndrome. Okay, we'll save time for questions at the end as well. So when I talk about selected causes of encephalitis, I'm going to break this down into sort of things that are common that I think some of the folks in this room have struggled with, and then things that are new or emerging that future participants in these conferences may come with. And I can never talk about encephalitis without starting my discussion of organisms with herpes simplex virus 1, or HSE. HSE stands for herpes simplex encephalitis. This is going back to the VORA study that I've already talked about, but in this national cohort of patients with encephalitis, herpes simplex virus 1 was the most common single cause of encephalitis. It accounted for 10 times more cases than the number 2 infectious cause, which is West Nile. So you can see that difference here, the orange being herpes, the purple being West Nile. Herpes accounted for a total of 13% of all hospitalizations, and double that of all known diagnosed hospitalizations. And it was overrepresented in terms of case fatality rate, causing about 21% of all deaths. We learn about herpes simplex in medical school. There's a lot of truisms that are taught, and I'll talk to you about sort of what the conventional thinking is about herpes first. It is true that it's the most common cause in the US, as I showed you. Herpes tends to localize to the temporal lobes. It can be unilateral, which is shown here in that white area there, or bilateral. We have a wonderful test for herpes. It's called a spinal fluid, or CSF, cerebrospinal fluid, PCR, polymerase chain reaction. It's a lot easier to call it a herpes CSF PCR, so that's what I'll refer it to. The sensitivity on that, we're taught in medical school, is about 100%, so it can't get much better than that. Treatment with acyclovir has been shown to be very, very effective. Studies before the advent of acyclovir documented a mortality of up to 70%. With acyclovir, it dropped to like less than 20%. And there are several prognostic factors that predict a poor outcome with herpes, some of which we can't change. One is the older age at presentation. Second is neurologic impairment at the time of presentation. But the third one is where I think lights should go on and bells should ding, because the sooner we give acyclovir, the better the outcome is for these patients. So that's what we're all taught in medical school, but in the last couple years it's become increasingly clear that maybe there's some variation in herpes encephalitis. This is a study out of the pediatric literature, a couple years old now, and these authors reviewed pediatric herpes simplex encephalitis and saw that there was some differences from what the standard understanding of herpes is. So it's become clear that atypical presentations of herpes are not that uncommon, seen in up to 25% of all cases. Again, this can be in pediatric patients, patients who have problems with their immune system at baseline, and patients who have pre-existing central nervous system or brain malignancies and are undergoing intracranial radiation. So these are populations who might not have that classic presentation. Things that we might see in these folks would be a slower or subacute onset of symptoms, sort of this much more delayed presentation, or very sudden presentation with no prodrome or no initial symptoms. Usually with herpes, we think of the spinal fluid being abnormal, but again, in some subset of these folks, it was very undistinguished. And the MRI, which again is usually showing focal uptake in the temporal lobe, can look normal. And so I think the combination of the recognition that herpes can present abnormally and the absolute need to treat people with acyclovir as soon as we possibly can led to the IEC, or International Encephalitis Consortium, defining that every patient with encephalitis should have HSV PCR, testing on the spinal fluid, looking for this very common pathogen, very common and very treatable pathogen.
Yeah. Did you make a final recommendation? Did you make a final recommendation on the time that the PCR must be done from presentation of the symptoms?
So
there was one before that was like 2 days, and I think that's too long. So if you could shorten.
there is no formal timeline, but we recommended that every patient with encephalitis should have a spinal tap, and that spinal fluid should be sent for PCR. And I will say sometimes the delay is not on the part of sending it, it's on the part of the lab performing it. Because at a lot of community labs, it needs to be sent to a commercial lab, and there's usually several days delay with that. So the recommendation in our guidelines, and predating our guidelines, I should say, is to start every patient with encephalitis on acyclovir and wait for the HSV PCR to come back before we decide what to do with it. Okay, so again, I won't go through this, but just again to highlight that having a standardized algorithm doesn't mean tons and tons of testing, but it means being smart about testing, and every patient should have this testing. So herpes PCR, I've already alluded to, is a wonderful test, almost 100%. Well, nothing's 100% in medicine, as you guys know. So this was an older study that looked at PCR, which was an emerging technique back in the 1990s, and comparing it to what the previous gold standard is, which was brain biopsy. Anybody here have brain biopsy for their diagnosis? No. That's probably a good thing. It's still used occasionally, but only in cases where the diagnosis is really mysterious. And so we had always recommended that patients with encephalitis be started on treatment with acyclovir, but the conventional wisdom was, this is such a great test that when it comes back negative, we can stop it. But that may not be true.
It's also inexpensive, correct?
Inexpensive?
Acyclovir is inexpensive.
Oh, acyclovir, yes. Well, you know, the IV formulation, which is what is recommended, is a lot more expensive than the pill formulation, but relative to almost anything else in medicine, it's relatively inexpensive, yes. So this, I won't go through the details, but this is a study that came out of the California Encephalitis Project that really changed practice. These are 3 patients, all of whom presented relatively early in their symptoms, between 1 and 3 days, and that's the second column there. All of whom had an HSV PCR in their spinal fluid that was negative. And so again, the conventional wisdom is we can stop acyclovir and look for other things or treat supportively. However, in these 3 cases, there was a lot of concern for this being a false negative test. And so these individuals underwent a second lumbar puncture several days into their hospitalization, between 4 and 7 days, which is the last column. And in all 3 cases, there was revision of the spinal tap to positive. And this was a game changer, and we emphasize this in our recommendations. So not only should you start acyclovir at the onset, if the PCR comes back negative and you're still really suspicious, keep it going. So again, really being very thoughtful about timing for stopping this therapy for a potentially treatable viral encephalitis.
So again, I quoted that very thing you highlighted. I quoted that very line you highlighted, but if you back up a slide, see how it doesn't actually say when the first test should be done?
Right, it does not. And point well taken.
Right,
I think again,
This was the problem.
yeah, I think maybe a subtext is that every patient with encephalitis should have a lumbar puncture as soon as it can possibly be performed, but I think being more explicit about it might be a good thing. Great. So I do want to touch on acyclovir treatment briefly. How many of you guys had acyclovir, if you remember? Okay, lots of folks in the room, good. It's, again, an important thing to consider at the onset. We've already talked about that. But even among the survivors, there are a lot of sequelae. Again, folks with herpes in this room are nodding to tell me they agree. And so there's been a lot of discussion about what could we do to improve that. And one theory was that perhaps the IV formulation of acyclovir knocked out the virus, but maybe there was still just a little bit there that was persisting and causing low-level inflammation. And to test this hypothesis, there was a study that was done through the NIH by the Collaborative Antiviral Study Group that looked at conventional treatment, which is 2 to 3 weeks of IV acyclovir, followed by 3 months of a acyclovir-like drug called valacyclovir or Valtrex. Was anybody involved in this study? They had a horrible time enrolling patients. There are a number of reasons why, but it was very slow to come to publication. So this was started more than 10 years ago, and the results were just published in end of 2015. And the bottom line is it did not show an improvement in outcomes in patients who had oral valacyclovir treatment. So we're gonna come back to this. I want you just to recall that prolonging oral antiviral therapy did not help with herpes, but we're gonna revisit this in a little later in the talk. And I'm gonna segue and talk about the second most common cause of encephalitis in the United States, and that's West Nile virus. Can I see a show of hands of who had West Nile here? So we had certainly a handful here. This slide just makes the point that West Nile was only recognized in the Western Hemisphere in 1999 or 1998, oops, sorry. And so it's a relatively new disease. And again, this is one of the reasons why I was surprised that we didn't see more changes in the overall incidence of encephalitis. For the first couple years, there was just a handful of cases, less than 100. It got a lot of press because it was new and exciting and dangerous. But in 2002 and then in the early 2000s, we saw a huge rise, not just in the number of cases, but an expansion of where the virus was occurring. Initially in New York City and then spreading westward to encompass the whole continental United States. There was also a sense that maybe it was burning itself out towards the late 2000s. You can see this huge drop off in the number of cases, and then it seems to be bumping up. And so I think the bottom line is the folks who specialize in West Nile at CDC are very frank and say we have no idea how many cases are coming or where they're going to be. This is what the map of West Nile virus, specifically neuroinvasive disease, looked like last year. The darker states had more disease. You can see the great state of Texas is sort of a nice navy here. But the highest incidence states were in the Dakotas and adjoining states up in that region.
So am I the only one that did New Hampshire?
Was it last year? This is just for 2016.
Oh, okay.
Yeah, it's not cumulative. West Nile has a predisposition to infect, or to cause disease, I shouldn't say infect, to cause disease in the elderly. And it's sort of counterintuitive. You would think that it's the kids who are playing outside in those mosquito-laden areas who would get bit all the time, and they probably do. For reasons that aren't clearly understood, older folks are at higher risk of developing neurologic disease with this. And it may have something to do with leaky vessels that allow the virus to transmit or transport into the brain tissue. There was a treatment trial for West Nile virus. It was started in 2003. It was looking at an Israeli product called Amoebic. It's just antibodies, but from a population that's already been exposed to West Nile. Sort of like getting a immunization through a transfusion. Anybody here involved in this trial? This was another one that was really, really challenging to enroll patients in, and I'll show you the results of it. It didn't work. Our best treatment for West Nile is still prevention, unfortunately. So slap those mosquitoes, put on your DEET, and avoid them. The results of the study really sort of got buried. I don't think they felt confident that the numbers allowed them to really comment too much on it, but it did not appear successful in terms of the population they studied. So our treatment for West Nile at this point is supportive care. We rule out any other infectious or non-infectious causes because we sure don't want to miss those. And then the emphasis really is on supporting patients in the hospital, respiratory support as needed, preventing secondary infections, and then rehabilitation. Okay. So if I had given this talk a decade ago, I would not have mentioned the autoimmune, and specifically the most common autoimmune disease that we're seeing, which is anti-NMDAR receptor encephalitis. Are you guys familiar with the Brain on Fire book? Yeah, okay. There we go. So I'm sure you guys all looked as lovely as Chloe Grace here when you're in your hospital bed. They're actually making a film out of this. And I'm not snarking at all because I think this is fantastic. This is going to raise recognition in the general population, in the medical population. I think this is only a good thing that this is coming out now. So I just wanted to emphasize the timeline just to give you a sense of how quickly things are moving in this area. It's really astonishing. The first cases of anti-NMDAR, and NMDAR stands, it's an abbreviation for a really long protein, but it's a protein that is present on the brain. And so anti-NMDAR refers to antibodies that attack that tissue in the brain. So it's an autoimmune encephality or autoimmune encephalitis. So in 2005, the first reports of 4 women who presented with encephalitis, all of whom had a GYN malignancy called a teratoma. So that was sort of striking. That was an unusual association. 2 years later, Joseph Dalmau, who is a neurologist who really is the grandfather of this syndrome and has done phenomenal work in this, identified this antibody that cross-reacted with tissue on these malignant cells as well as in the brain. And so again, defining this as an autoimmune process. And within 4 years of the recognition or identification of this protein, there were more than 400 cases identified. So this is not a rare syndrome at all. With improved diagnostics, it was shown that you don't have to have an ovarian teratoma, and not all these patients are women. So this is a study that looked at patients who had definite NMDAR encephalitis. Those are the bars. In the population that was 18 years or older, about half of the women had these tumors present, half didn't. But in the younger girls, almost none of them had evidence of tumor. And we have expanded that as well to say it can happen in men, and certainly tumor is not universal. To give you a sense of the importance of this syndrome, this is data published by Carol's group from the California Encephalitis Project. This entity was really diagnosed after our studies had stopped, which is really a shame, but she went back to her banked specimens of all the patients who had unknown encephalitis that were 30 years or younger and did testing on them. And she found that the prevalence of anti-NMDAR encephalitis in that population was higher than any single viral cause of encephalitis. So it was sort of a sleeping giant in our studies, we think. Because it's so new, we still have a lot to learn about it. Does anybody know about Newt the polar bear? Yay, okay. I love it. If I ever give this talk in a group that has Europeans in it, they get excited when I show this slide. So Newt made the cover of Vanity Fair, and it's for sort of a sad reason. He was a really cute little polar bear at the Berlin Zoo, and he started having neurologic deficits. And there's his zookeeper having to carry him, and he ended up actually drowning in his pool at the zoo, and they did a post-mortem on him, and he had NMDAR encephalitis. And so again, he sort of is the poster child, but has brought a lot of recognition to the syndrome in Europe. So I think we've been a little slower to catch up in terms of recognizing it, but I think that may be changing. And one area that sort of brings together the infectious and autoimmune communities is this new recognition that these two things are not necessarily distinct. And this is perhaps one of the most exciting and important things in encephalitis research in the last 10 years. There's a recognition, again, not all these cases have a teratoma or tumor that drive them, and there was a suspicion that maybe infections could be another cause. In 2013, it was recognized that patients who had herpes simplex encephalitis may also get autoimmune encephalitis. And it's really shown pretty nice graphically here. So I don't think I have a pointer, but if you look at the gray area, that is, the higher the gray is, that's the more neurologic deficits. This is a case report of an 8-year-old boy who came in with seizures. His PCR for herpes was positive. He was appropriately started on acyclovir. You can see that gray go down really nicely, just like you want it to. So he went back to baseline, he finished his acyclovir course, and 2 days later, represented with abnormal movement, a movement disorder. And he was started back on acyclovir, did not get better. HSV PCR now negative, but at this juncture, NMDAR antibodies were checked, and they were positive. And so I think this is a beautiful graphical representation of what one might expect. Initially, a viral encephalitis, got better with treatment, recurred, not due to virus, now due to autoimmune.
What are the lines, Carol?
So the lines are the levels of NMDAR antibodies in the, I think the top one's CSF and the bottom one is in blood. It's a really busy slide, but I think if you just sort of, first gray bar is virus, second gray bar is autoimmune, it makes a lot more sense.
Those are the days on the bottom there?
Those are the days.
Do you think that the viral encephalitis, the first, the HSV, caused the blood-brain barrier to break down, and that allowed for the subsequent NMDA receptor encephalitis to happen? Because I've seen double encephalitis before, and I've always wondered if that's true.
That may have a role. It certainly makes sense. I think the other thing is that the viral infection may have, again, overstimulated the immune system to sort of dysregulate and produce a host of antibodies against herpes, but also against things that it had no business producing antibodies to. And probably this disordered immune system, perhaps coupled with that leaky cerebral vasculature, led to this. And this may be more common than we previously recognized, so I'm going to go back to that study that was done looking at the prolonged oral course of antiviral for herpes simplex encephalitis. So remember, these investigators didn't find any benefit to giving pills for 3 months after strong IV therapy. But they had this specimen banked, and so they went back and looked at it to see how often they can find this autoimmune antibody, this NMDAR antibody. None of the patients on day 0, when they first came in with herpes simplex encephalitis, had evidence of this. But by 90 days, 3 months, a quarter of them had anti-NMDAR antibodies in their spinal fluid. So the question is, so what? None of these patients had clinical evidence of recurrent encephalitis. So unlike that graph I showed where that kid got really sick and came back into the hospital, none of these patients were thought to have ongoing symptoms. However, all these patients, as part of the study of the antiviral therapy, had fairly sophisticated testing done for outcomes. And when they looked at the outcomes, there was no difference at 3 months in those who had the autoimmune antibody and those that didn't. But there was less improvement in the subgroup who had the autoimmune antibody. And I know that's something that would make ears prick up here, because we are all into improvement. And so it may be that there is some significance of developing autoimmune encephalitis after viral encephalitis. And this is sort of a book that the last chapter is not known on. But I will say that the recognition that this is a phenomenon that needs to be considered was apparent. And so this is, again, out of the International Encephalitis Consortium guidelines. We said that all patients who experience recurrence of neurologic symptoms after an episode of viral, either HSV or VZV encephalitis, should be tested for autoimmune encephalitis. And I think that's a valid recommendation. Yes?
Is there a rational used treatment regime for autoimmune encephalitis? Because, say that again.
Is there a rational and understood treatment regime for autoimmune encephalitis? Because I've been told the response to symptomology at least 5 or 8 years ago was the same. So they didn't even, they did.
So I'm going to break it down a little bit more. So for NMDAR encephalitis, there is treatment guidelines for it. The initial treatment is usually very high dose steroids, and then there are ancillary treatments as well. It could be exchange transfusions. It can be some chemotherapeutic drugs. So there are a number of different treatments. That's usually in the purview of the neurologist. But yes, there are very effective treatments at this point. Interestingly, total segue, one of the treatments that's really effective is taking away what we in medicine call the antigenic stimulus. So removing what seems to be driving this disordered antibody response. So patients who have those tumors taken out, those ovarian teratomas, sometimes that's all they need, and they get better just with that without any other medication. So that's sort of fascinating. So again, I don't have a lot of answers. I just bring this up as something that we're seeing and learning more about. Yes? Wait.
So the treatment for the anti-NMDA, my daughter has been doing IVIG infusion for 2 years, every 2 to 3 weeks. And so she gets it, and then she goes down, and she gets it, she goes back up, and then she gets it, she goes back down. So that's been the only treatment that she's been doing, and it's helped from having seizures daily to maybe about 8 to 10 a month that I'm aware of, and then less pain in her legs, but she's still unable to walk. That's the only treatment. So is this going to be like a lifelong treatment?
So that is, again, a disease that's managed more by the neurologist than the infectious disease teams. There are some other treatments that I'm aware of. Her doctors may have felt that that was the very best one for her. And I don't know if anybody really knows, because this is such a new disease, how long to treat people for. Often in the hospital they're treated, at least until they get better. Obviously, it's all individualized based on the patient's response. So I will say that this is an area of intense interest, and particularly the role of autoimmunity in infectious encephalitis. There's a study that is ongoing in Europe right now, looking at giving patients with herpes encephalitis not just IVA cyclovir, which we know is life-saving, but also giving steroids. And so I think we'll get a lot more information in the next couple of years about this. Okay, I'm going to segue from the known to the newer. Any questions? Okay, and I'll go pretty quickly. Or not. So you've all seen these horrific pictures of the children with microcephaly due to Zika virus, but I think it's becoming increasingly recognized that Zika can have effects on brains outside of the neonatal period, and specifically that it can cause encephalitis. I gave a talk in October at our ID meeting looking at emerging causes of encephalitis, and at that point there were 4 case reports of patients with Zika virus encephalitis, all of whom had very well documented cases. The presentation seemed non-specific. The outcome, as you can see, varies. 2 of them had complete recovery. One passed away from the disease, and one had neurologic deficits. And So 4 cases isn't a whole lot, but I think there's reason to think that it may be just the tip of the iceberg. This is an area, a developing area in Brazil, not a lot of resources, not a lot of surveillance capabilities. And these investigators looked over time, again using sort of a broad stroke, looking at hospital discharge diagnoses, and we all know how rotten those are, but looking for encephalitis. And they looked in 2 different regions. One is an area where Zika became very, very prevalent, and I think that's the northeast region, and that's the darker lines, and it's a little hard to see on this. And the lighter gray line is an area in Brazil that did not get affected nearly to the extent by Zika virus. And these numbers really sort of jive until about 2014, 2015, which is when Zika became endemic in that region. And after that, you can see this huge jump up in cases of encephalitis in the northeast region. There was a 220 times increase in encephalitis hospitalizations. And so that could mean that Zika is causing significantly more encephalitis. But it's not the only virus that was circulating in Brazil at that time. You guys heard of chikungunya? Sort of a mouthful. Sort of one of the, it actually is older than Zika, but it was like a year or 2 before it. This is a virus that was common in equatorial Africa and jumped over to South and Central America, now also occasionally seen in the United States. It usually causes a severe viral illness with a lot of joint pain and swelling and rash, but it's become apparent that it can also cause brain infection. So this is a series of cases out of the Reunion Island. They identified almost 60 cases who had chikungunya, who developed neurologic disease. About half of them had encephalitis. This seemed to manifest most significantly in the very young kids and the very old. And the outcomes were poor, particularly in the elderly. There was a 16% mortality. Adults did worse in terms of survival, but in the younger children, there were probably some long-term developmental effects. So this may be a very serious long-term disease. And so La Reunion Island seems really, really far away from us. But I wanted to show you, this is a slide from the CDC looking at chikungunya activity in the United States, and it becomes a little bit more pertinent, I think. The light blue states are areas where chikungunya was diagnosed in 2015. And here again in the great state of Texas, there was endemic transmission, meaning that folks didn't come after vacationing in Puerto Rico home with it, but they developed chikungunya after being bit by mosquitoes in their environment. So there's certainly the potential that it could become entrenched here in the United States, particularly the southern United States. There were cases in Florida the previous year as well that were native. So I've talked about 2 mosquito-borne emerging encephalitis causes that have come from the south, and I wanted to do due diligence to our friends from the north. There's a tick-borne disease that we're hearing more and more about. We're probably underestimating. This is called Powassan virus. Have you guys heard of that? I'm seeing my Canadian colleagues. Okay, yeah, the New Yorkers and the folks from Canada are more aware of this. So again, it's not terribly common, but the numbers are rising. You can see in 2004, 2006, 1 case, and then as numbers go up into the double digits, so not huge numbers. What's interesting from an environmental perspective is one of the reasons that it is emerging and why we're worried that it may continue to emerge is a change in the tick vector. So this top one is sort of this wimpy little tick that was usually responsible. It's called Ixodes cookii. And it doesn't like to bite humans. It's shy, it's retiring, and that's been sort of traditionally thought to be the vector. The guy on the bottom is a real stinker. That's Ixodes scapularis, and that's the one that causes Lyme disease, and that loves to bite humans. And it's very aggressive, and it's very widespread throughout the northeast United States. And so this is the new vector. Some people call it deer tick encephalitis. You guys may have heard that name rather than Powassan. So this is the deer tick encephalitis virus. This slide also, I think, gives us some concern that this may be an emerging pathogen. The disease historically had been only seen in the very upper portion of the northeast United States, in Maine and New Hampshire and Vermont. And then in the mid-2000s, we started seeing cases sort of along the Atlantic seaboard that had never had a case before. This is a series of 8 patients with Powassan encephalitis. I won't go into huge detail, just to say, it is a serious disease. 2 of these 8 patients passed away. And one reason why I think this is underdiagnosed is the only testing available is through CDC. There's no commercial lab doing testing right now. And so you have to not only think of the diagnosis, you have to get it to the right people to do the testing for it, which really makes it a barrier to making this diagnosis.
Karen, is there a time limit from getting it to the CDC that it's still active?
So it's antibody testing for the most part. So actually, if you wait a little while, you're going to get better tests for it because the antibody has had time to develop. They can do testing on both spinal fluid and serum. Ideally, it's on spinal fluid. Okay, I'm going to move away from the insect-borne encephalitides and talk about a real mystery illness. This is acute flaccid paralysis. And I have as a photo here something that's a throwback to the days of polio. Polio is a virus that causes, it's a virus caused by the polio virus, which is a member of a larger class called the enteroviruses. So it becomes significant in a little while. So polio has been essentially eradicated from, well, it's been eradicated from the United States for sure, but close to eradicated throughout the world. In 2014, there was a large outbreak of respiratory illnesses in pediatric kids. It was serious diseases. It was way above what was expected. Pediatric ICUs were filling up, and it was clearly something different going on. And in these cases, in a number of cases, this enterovirus called enterovirus or EVD68 was identified. In that summer, the CDC, which does testing to subtype in enteroviruses, identified this EVD68 strain in 36% of the specimens they received, and that's not spinal fluid, that's in respiratory specimens. And in comparison to next year, none of the specimens they received. So it was clearly a big outbreak. And it was against this outbreak of respiratory illness due to one of the enteroviruses that this new syndrome of acute flaccid paralysis in kids, sort of reminiscent of the polio epidemic of the 50s and such, was becoming apparent. There were 2 reports, one out of California, one out of Colorado, of children with this syndrome. This led to the CDC doing an investigation. This is a paper by Jim Sabar that came out in the last year. He identified 120 individuals with acute flaccid myelitis or acute flaccid paralysis, a polio-like syndrome. Most of these were kids. More than 80% had a respiratory prodrome, had illness involving the respiratory tract before they came down with the neurologic disease. Many of them had fevers. There wasn't a lot of inflammation in the spinal fluid. And in 20% of these cases, they were able to identify this EVD68 virus in respiratory specimens. Not a single one had it in the spinal fluid. So again, this relationship remains a little bit tenuous and a little bit unproven. But I think there is a sense, sort of bookending this chapter on acute flaccid paralysis, that maybe this is yet another emerging cause of a polio-like illness. Fortunately, last year was very light, so hopefully it's something that won't come back. So I know this is a group that's interested in treatment, and I did want to talk about a new treatment for one of the more deadly causes of encephalitis, brain-eating amoeba. It's got such a catchy name. Medically, we call this primary Amebic Meningoencephalitis, or PAM. This is sort of classically associated with recreational activities in water. This gets a lot of play. I think every year there are a couple cases reported in the news. It's usually young kids, such as our friend here, healthy. Again, the risk factor is water under pressure going into the nasal cavity, and it penetrates into the frontal lobe and causes infection through that route. It's a amoeba that loves warm water, and so classically it has involved cases in the coastal United States. But there's some new ways people can get it that have been identified. This gentleman with the neti pot is putting himself at risk if he's not using sterile water. In Muslim tradition, there's something called ritual nasal ablution that can lead to it. There have been cases reported in the Middle East. And there's been at least one case associated with a slip and slide where a kid went, rolling down it, water under pressure went up the nose. So again, it's not the most common disease, but there were 138 cases in the last 60 or so years, 50 years, I guess. And what's different and what's notable is this is a disease that has historically occurred in these coastal regions, And you can start to see there's some migration. There have been cases now in Missouri, Kansas, Indiana, and several in Minnesota, which would not be an area with, when we think of with warm water. And there's been some supposition that maybe warming temperatures in water bodies may be playing a role with it. So again, 138 cases, not so many, but it's a very serious, deadly disease. Only about a quarter of patients are diagnosed before death. And part of that is because death occurs so quickly in this population within 5 days of presentation. So recognition is key now that we may have a treatment for it. Before 2013, there'd only been three survivors among this large cohort. In 2013, there were 2 additional survivors, and then last year, this young boy also survived. And what's different? This drug that's now commercially available in the United States, it's called miltepacine. Maybe you're pronouncing that wrong, but that's how I pronounce it. So miltepacine is not a new drug. It's been available internationally for quite a long time. It treats a very rare parasitic skin disease called leishmania. But in 2014, it was licensed by the FDA for treatment, and CDC made this drug available off licensure for use in these very serious amoebic brain infections. It's now being made by a pharmaceutical company, and they're doing something really, really smart. They're actually stocking it in hospitals in the coast, sort of in the hope that if a case comes in, it can be recognized really quickly, and treatment can be started immediately. And so not only is this drug effective against this somewhat rare but very, very serious amoebic infection, there's a second amoebic infection, also rare, that it is active against. This is called granulomatous amoebic encephalitis. It's a much more subacute but no less deadly infection. Unlike the previous one, it's more in soil than in water, and so folks who are exposed to soil, firefighters, gardeners, construction workers, folks who are ATVing outside. And there's been one case report of somebody who was snorting cocaine using ditch water who got this infection. So it is also treatable with miltepacine in combination with a number of other drugs, and there's a suggestion that it can be quite effective in the therapy. And so I'll just leave the amoebic encephalitides by saying we tend to think of these as rare, but maybe they're not quite as rare as we've recognized. There hasn't been a priority in making diagnosis if there's no treatment. Balamuthia is the parasite that causes the one I just talked about, the granulomatous Amebic Meningoencephalitis, the dirt-loving amoeba. And there have been 2 reports now of clusters of cases. Those are a little easier to identify associated with transplant. And so if these clusters are occurring in this fairly rare transplant setting, it's likely there's a lot going undiagnosed in the community. Okay, I'm going to move on, talk about new diagnostics. In my mind, this is one of the more exciting and novel things that's happened in encephalitis. I've pounded into your head that 50% of cases go undiagnosed, and so you can see the power of this for improving our diagnostic yield. And I'm going to talk you through a case study that came out a couple of years ago in the New England Journal of Medicine. So this technique is called next generation sequencing, and it's a totally new way to look for infection. This is a case report of a 14-year-old boy who was admitted on hospital day 0, and the numbers at the bottom are days, hospital days, with fever and confusion, multiple lumbar punctures, actually underwent a brain biopsy on about day 15 or 16 there, non-diagnostic, continued to decline. He was put on a ventilator or breathing machine, actually then put into a coma for protection of the brain when his seizures became so severe that they couldn't be controlled. And at this point, the team said, let's, Hail Mary, send off this specimen for this newly developed test, not commercially available. Within 48 hours, the spinal fluid had detected a signal for a bacteria called leptospirosis. He was started on therapy with penicillin, our oldest antibiotic that we have. He improved fairly quickly. By day 60, he was able to ambulate independently, and by day 76, he was discharged from the hospital. So I think that really illustrates the power of this new technique. And I'm not going to go into great detail about this, mostly because I don't really understand it, but it is a way to amplify any genetic material that's present in a specimen. And so these techniques amplify host, meaning human DNA. They amplify anything that's not supposed to be there. And then these sequences are fed into a very sophisticated electronic library and matched, and they subtract out the human sequences and see what's there that isn't supposed to be. So the advantage is it's unbiased, meaning as a physician, I don't have to suspect leptospirosis. This is going to pick up whatever's there. And I think that's always been a big barrier to making diagnosis in these rare or unknown diseases. So that's an advantage. It's rapid, and it can be done on both CSF or brain tissue. The disadvantages is, not surprisingly, it's costly. It's not widely available. It's only in research settings at this point. But I think the big challenge is it's so good, it amplifies so much, that sometimes what it amplifies is junk. So it can sometimes amplify viruses that are just sort of latently living in cells, not causing problems. And so it really takes some expertise to tease out the meaning of a finding from this. But that being said, I think there's a lot of promise for this technique. So I want to come back to the objectives. What is encephalitis? Well, the technical definition is brain dysfunction with inflammation, but practically that can be defined using sort of a combination of clinical clues from presentation. And now that we have a standardized case definition, hopefully it'll lead to improved recognition early on, and it'll improve our ability to perform standardized studies. What's new? We've talked about sort of what's new with known bugs, but I also want to emphasize there's some new organisms that we have to be aware of. There's some mosquito-borne bugs, Zika and chikungunya. There's a tick-borne bug, Powassan virus. There's this emerging syndrome of acute flaccid paralysis like polio that may or may not be associated with enterovirus D68. And of course, our autoimmune spectrum continues to grow. Our new drug, again, treats a fairly small slice of the pie, just these amoebic encephalitis, but it's very promising in diseases that used to be uniformly fatal. And then there's this evolving sense that maybe steroids have a role outside of just autoimmune. Maybe there's a role for them in infectious encephalitis as well. And with new diagnostics, it may be that down the road we'll have an improved ability to make identification of organisms early on in the hospital course. So I wanted to end the talk emphasizing some knowledge gaps and some opportunities. And knowledge gaps are many, but the ones I wanted to at least highlight in my mind that are important is the fact that 50% or more of cases continue to go undiagnosed. Even when we make a diagnosis, we're not always certain what the best treatment is, and I think there is ongoing studies that hopefully will clarify that for us. We're just learning about the role of autoimmunity after encephalitis, and I think that's going to be a really hot area in the next couple of years. And then something that's been really brought home at this meeting to me is the importance of rehabilitation following a diagnosis of encephalitis. In terms of opportunities, I think we could probably do several slides on this one, but I just wanted to bring forward some that came to my mind. I think in general, we in the medical community work in silos. So the infectious disease doctors do their thing, the neurologists do their thing, the rehab doctors do their thing. And one of the really eye-opening things about the International Encephalitis Consortium is getting experts in a number of different disciplines in a room, and we really feed off each other and really sort of, I think, can improve the care of the encephalitis patient by working as a group. CDC does not do a coordinated surveillance for encephalitis, which is a shame. So if there are some of these emerging organisms that are becoming more prevalent, it may be a period of time before we know about it, particularly in diseases that aren't easy to test, like Powassan. We need to improve recognition of encephalitis, knowing that earlier treatment can correlate with better outcomes. I think the IEC has focused on developing best practice models and professional guidelines, and I think this is an area that needs to continue to grow. Encephalitis has very few studies looking at long-term outcomes, and I think that's a real detriment, and I think that's something we could improve on. Something that you guys are the expert on, the transition from inpatient to outpatient care can be extremely rocky, and I don't think we do a good job in that arena. Rehab, we've talked about extensively. I think on the medical side, education of providers is key, and that can be sort of first responders, the ER doctors, the primary care doctors, the interns. I think there are a lot of areas we could improve on. And recruitment of young faculty who might have interest in encephalitis is going to help grow the field. advocacy is something you guys have done a lot for. I think that's a real strength of this group, and in funding, which is something that we all struggle for, and something that encephalitis has historically not done as well with. So I'll end the talk, but I'm more than happy to take questions.